tumor growing in your lung, you don't just ignore it and say, hey, all's fine, let's just leave it be and, hope that one day it'll go away. So I think in a very similar fashion, if there are issues on the ground, I think it is important for the powers that be to acknowledge these problems and find ways in which people can voice their maybe not necessarily dissatisfaction, but how difficult it is for them to function normally, how difficult it is for them to provide the best care possible. And these are people who, on a daily basis, are dealing with other people's lives. So I think it would be important to listen to this sense of, I suppose, all the despair that's emanating from the ground, from the front lines. And as a result, figure out what would be the next steps in order to address these situations. I think it is wrong to want to sweep things under the carpet, which some people feel is what's being done by some others. Notice all my disclaimers, right? I'm trying not to get into trouble here.
The disclaimers, yes. The apparently, allegedly
that this happened by someone. Name shall remain unsaid and blah, blah, blah. Yes. But I suppose jokes aside, I think we, you and I, we are very much, I suppose, entrenched in the medical fraternity. I think you lie in bed with one. So, you have people who basically tell us all the stories of what's happening on the front line. And I think it's very disheartening at times.
Yeah. And it's also very, quite annoying because like you hear all this, I mean, I've been reading the messages forwarded by my friends who will remain unnamed, of how they're overworked, they're breaking down figuratively and literally, and there are too many cases to handle. And then, when there's a site visit by very important people, suddenly there are stories of how like they cleared up the area to make it look as if the hospital's not in disaster. When to me, you should show the disaster so that you get help, right? It just runs contra to what you should be doing. Instead of asking for help, you think, I don't need help. When in fact, your hospital is literally crumbling down.
I think that goes beyond just healthcare. I think in a sense, most of us here, I think, people who are probably listening, who are watching, people who are on the ground facing the difficulties and challenges of living in a lockdown, I don't think they need to go very far to either experience the difficulties themselves or to see how it's affecting a loved one or a close one. And once again, trying to show that things are all fine and dandy when they're not, I think is very disingenuous, because ultimately I think it just increases dissatisfaction. It increases the anger and the frustration that people feel. People need to be, I think one needs to be a bit more empathic. You need to be able to show people that you understand what you're going through or what they're going through. And as a consequence, they too feel that, yes, they're listened to. Perhaps the solutions may not be the best solution in the world, but if it's done with the best interests and the best, I suppose, the best
intentions.
Yeah, what we call nawaitu, that's important, I think. And I think if people get that sense, then, people aren't stupid. People know that it's a pandemic. People know that difficult decisions need to be made. It's just when they see things being made for reasons that perhaps are not necessarily for the betterment of the country, that's when they get annoyed.
Yeah. Another group that's been very much annoyed, as I touched on earlier, is that this group of contract doctors. I mean, you're in a private practice, of course, but the public service, the public sector, the new doctors that come in, they don't get a fair shake. I was speaking to the chairperson of SCOMOS last week, and he says that they're trying their best to get a fair shake. And what's nice is that a lot of the senior doctors are also supporting the junior doctors to get a fair shake. Do you think we'll have like a positive outcome, especially now that we need doctors actually during this pandemic?
I think there will be some outcome that would perhaps put a plaster on the wound. But once again, going beyond just what's going on now, you would hope that one of the lessons we learned from this pandemic is the importance of ensuring that our healthcare services are sufficiently funded. So, for example, as a percentage of GDP, the Ministry of Health doesn't get as much a percentage as more comparable or more developed countries. So, and that goes back to what you said earlier on. If you have hospitals that are crumbling, somebody mentioned to me that Klang Hospital, for example, has been there since the 1970s. And, you don't necessarily get the same growth in space and in infrastructure that befits a hospital that serves a certain population in this modern day and age. So you've got the infrastructure that's physical in nature, you've got the infrastructure that is digital in nature as we move forward. But I think most importantly, and I suppose the resource that's most important is the human capital, and ensuring that the people who are trained, the people who have been training, are given the opportunity to, I suppose, do the right thing in terms of their career progression. I mean, one thing we can all agree is that we need more public health experts. So you would think that once again, in the next 5 to 10 years, you'd be having a particular pathway that would enable people to capture and to ride the zeitgeist, right? In terms of this whole thing, there will be a certain moment of time where being a public health expert is very important, and everyone will think, yes, we should do that. Let's go for it. But in 5 years, when things are a little bit more settled, they'll think, dah lepas, dah tak ada, tak payah buat. And then in 10 years, when when another pandemic happens from another particular virus, then they'll be like, oh, we should have spent more money back then. So it's this kind of, I think, very vicious cycle that I think needs to be halted. But it goes back to ensuring that there are adequate investment in not just the physical side of healthcare, but in the people who are actually keeping it alive and keeping things going.
I really like your optimism when you say that in 10 years' time, there's another pandemic from another virus. What makes you think we're going to get out of this one in 10 years' time?
We will get out of it. But in what way, and whether it's the way that you and I want, that's a whole different question.
Yeah. The virus will burn off, but how many people it takes along with it, lah. That's the main question. So a broader question about our pandemic response. You as a respiratory physician, how do you feel our pandemic response has been? And you touched on it a bit earlier. Like, how optimistic are you that maybe next year things will be better? What are your thoughts?
I think perhaps the most optimistic thing that one could latch onto at the moment is the rate in which people are being vaccinated. I think at this point in time, it's something like over 400,000 a day. So that's pretty impressive. And if you compare it with countries across the globe, we're doing rather well. I mean, it's easy to focus on all the negative things and to moan and, I suppose just rant on about how bad things are. But this is one aspect that I think we have done relatively well. A lot of the issues when it comes to giving vaccines are also dependent on what's supplied to us by manufacturing countries, because unfortunately we can't become a vaccine producing country overnight. So we are dependent on the deals, the negotiations, all of which have happened behind the scenes with countries across the globe. And as you can see, once the supply has increased, the rate of vaccination has increased as well. So that's something that I think is positive, something that's very important, because one of the key weapons that we will have in combating the pandemic is the issue of vaccination. What I feel has not been done as well is when it comes to the various SOPs, the manner in which we have had crisis comms, or rather the lack of it. Because I think in many ways there are individuals who give more confusing statements rather than clarity. And you have situations where you have SOPs where no one's quite sure what applies, what does not. Things may change from one day to another. And if we were to compare ourselves with other countries where there are clearer and easier to understand SOPs, it also means that everyone, or perhaps the majority of society, is able to follow them without much problems. Like right now, if you were to ask me, what are the SOPs for factories, for example, I wouldn't know without looking into what, I suppose it's not my industry. But, even like going out, I'm not 100% sure at this point in time if I can go out with one person or two people in the car, right? Because it just changes all the time. So to err on the side of caution, we just don't go out.
Yeah.
But you can see how that can impact activity, can impact movement. And I think the other thing that we could do better is perhaps be a little bit more, I think, a little bit more specific, a little bit more granular when it comes to the SOPs. There is no logic in, say, shutting down the entirety of Malaysia when cases are concentrated in only certain states. Same thing within, say, KL or Selangor. There are certain places where things aren't too bad, then logically one should be able to go out a bit more. Things like keeping parks open, keeping people active, keeping people mobile, making that they have an outlet where they don't get too stressed, where they can de-stress from all the mental health implications of being locked in. These are certain things that I feel could be done better as well. So I think there is this whole spectrum of what has been done well, what hasn't been done well. And I think the problem is because there is a lack of clarity, because there is a lack of, I suppose, a lack of clarity also in terms of where we're headed. And people start to despair. It's once again, if you have a light at the end of the tunnel, then people can reach towards it or move towards it. But all you see is tunnel, and you just hear noises and you hear people saying things without really knowing in which direction you're going, then you just drown in despair.
Yeah. So the main reason I wanted to talk to you was because like I want to get to know the clinical aspect of COVID-19. Now, what is there like a telltale constellation of signs and symptoms that should alert someone? Oh, I may have COVID, or is it still very is it still very non-specific?
It is non-specific because it's a respiratory. I mean, by and large, we have respiratory symptoms, but there isn't any specific thing that would say, this is COVID and this is not, say, influenza. I mean, people always say one of the key things is if you lose your sense of smell. So if you lose your sense of smell, it's kind of COVID until proven otherwise. On the flip side, if people have perfect sense of smell and they have COVID, I think the kind of logical way to approach things is, given the fact that we are in the middle of a pandemic in which numbers are in the thousands, then if you were to have respiratory type symptoms, so like a flu-like illness where you have a runny nose, a sore throat, a fever, if you have body aches, if your joints are achy, if you feel like you've got a lack or drop in appetite, these sort of constellation of symptoms, to me, in the current context, would be COVID until proven otherwise. And of course, if you were to be in close contact with someone who's positive, then the risk would go up significantly. So I think in the old days, if you had these symptoms, you might think, it's just a cold lah. Give it 2-3 days, I'll be better. I'll be Panadol. Then if things don't get better, go to your GP and get, whatever. But I think now, in today's situation, if you want to get that, then the faster you test yourself, the better. Because A, if you are positive, then there are implications in terms of your own personal individual health. But just as importantly, secondly, there are implications in terms of how you may potentially spread the disease to others. So I think those are the reasons why, if you have symptoms, testing early is fairly crucial.
All right. I think to all the viewers listening, watching, I think that's a very important phrase, that until proven otherwise. I think that's really, really important. And like I said, like he said, Dr. Helmy puts in a very nice context. We are in a pandemic now, so you better think you have COVID and then get tested and then find out negative, rather than not getting tested and then walk around spreading COVID to thousands of people, literally thousands, not an exaggeration. Professor Gauss, who I spoke to 2 weeks ago, he is, I think, tuning in. Hello, Prof. And he asked me to ask you about long COVID. Okay, and my wife, who is an anesthetist, also wants to know about long COVID. What do we know about it? What do you know about it? And what happens in long COVID?
So long COVID syndrome is a constellation of symptoms that can occur in some individuals who have suffered from COVID. Now, maybe to take a step back, even with COVID itself, the majority of people, 2/3, even 3/4 of people, may not have symptoms or may have very mild symptoms and recover fully without any problems whatsoever. But let's say about 1/3 of people, they end up needing hospitalization, they end up needing care in terms of medication, and in a much smaller number of people, you end up having to go to even ICU because you have had issues with your lungs, there's been inflammation in the lungs, leading to the point where you need oxygen, and in very severe cases, the lack of oxygen leads to multi-organ failure, because every single organ in your body is dependent on oxygen supply. And if your lungs is unable to get oxygen to the rest of the body, then things start to die off. So it's kind of as simple as that. Now, you may recover, but have residual damage. So for example, the lungs itself, it's like, if you have a very bad wound, if someone were to slash you with a knife, you get all this inflammation, you get a very raw kind of picture. But as time goes by, it heals. It gets back to normal, except for a scar. Now, that scar, even on your skin, doesn't go away. It's there forever. But that bit of skin that is scarred will also not function as per normal skin. It's thicker, maybe It may be a bit itchy at times. It may not be able to control temperature the way as other parts of your skin does. Now imagine that happens in your lungs. The lungs that have been inflamed, they end up being scarred, which means they're thicker, which means oxygen cannot go in. And if it's significant enough, if most of your lungs were to be scarred, then you may have a situation where someone is dependent on oxygen for the rest of their life, even if they survive the disease. And one of the common names that have been thrown around is fibrosis. And fibrosis is essentially this, where you have scarring of the lungs. Now, you're quite lucky in that most of us have lots of reserves, where you can imagine someone who is, say, a smoker or someone who is more elderly, your backup, your supply or your reserves are very minimal. And if you use them up, all scarred, you get a situation where you can't walk around much, you may need oxygen, and this is only the lungs. So in this long COVID syndrome, you've got multiple situations, or rather multiple ways in which you can have long-term symptoms. So even things like you mentioned, the loss of smell, that can last for many months. And we may think it's not much, but just imagine the rest of your life where you can't taste food. I'm sure, it's depressing. Now, thankfully, studies would indicate that by 12 months, most people, I'm talking about over 90% of people, regain those senses. So it's not something that is there forever. But other things like being very, very lethargic, being very drained, just very tired, even if your lungs are normal, your lungs are working well, the whole body's sort of stamina, so as if your battery has been completely depleted and it's taking time to recover. It's a very common kind of symptom when it comes to long COVID as well. And some people do complain of having what we call a brain fog, where essentially you're a bit slow. You're not as switched on as before. It takes longer for you to make decisions. Your memory gets affected. And nobody really knows who will get what and when. So if I were to touch wood get COVID, then I'm not going to be able to know which symptoms will affect me. But these are all different things in which I can be affected, not just during those few days or few weeks where I'm being treated actively for COVID, but in the long term as well. And that's where it becomes very tricky, because we keep focusing on the numbers. We look at the number of cases, number of deaths, but we don't really look into the consequences of having COVID. And this is purely so far a conversation about the physical consequences. There is the whole mental health aspect as well, which I would argue is as important, if not more so, for many people who have gone through suffering from COVID.
So, Dr. Helmy, this is very interesting. Can you expand further on the mental health aspects of people who suffer from COVID? What are the things that we don't know or we rarely talk about?
I suppose if we were to imagine ourselves as a patient, right? So let's say I am an elderly person who has been told I've got COVID, and then I get, swept away to a hospital where I'm in a room by myself with no company. In that room, I'm visited daily by people whose face I can't see because everyone's gowned up, everyone's wearing full protective gear. So my only interaction is people who come in as quickly as they can because they don't want to catch my virus, right? They talk to me, and that's it. Now, if I'm lucky, I may have an iPad, I may have an iPhone, or maybe brand conscious, I may have a smartphone where you can have, video conversations with people. And that may alleviate the loneliness. But if you're someone who doesn't have that, or if you're someone in a place where it's very packed, all you have is your own thoughts, which in most cases is going to turn very negative because all you hear about is how people are dying from COVID, right? Times that by multiple days. Imagine you're in that situation alone by yourself over, say, 2 weeks. Things may get better, things may get worse. When things get worse, you end up being very worried. So the level of anxiety goes up. The level of depression goes up because you're lonely. You feel that there's nothing left to live for. You feel that you're getting weak. You think that, oh my God, it's just the rest of my life. Now, if you're lucky, once again, you get better. You get out of ICU, you get out of the hospital, but then you will go back into a situation where you've suffered through all this, So your scars are not just physical, your scars are mental as well. You've got many people who feel really down, who feel very anxious after being discharged. And most of my patients, they are actually a lot more cognizant, they're a lot more alert as to the SOPs and the mask and things like that after they've contracted COVID compared to before. Because before you get it, it's a very abstract thing, right? It's something that happens to people but never happens to me. And once I get it, I'm like, God, this is bad. And then you become careful. So that's in someone normal. When I say normal, I mean someone with no pre-existing issues. But imagine you've got other issues, right? You've got heart disease, you've got diabetes, you already have an existing anxiety problem or depression. All that can be exacerbated by this experience. And that is with the individual. The family is also affected. I'll give you an example. Dying of COVID is a very lonely experience. So if you think about it, if you have somebody who is once again locked up in a room by themselves, where they're getting worse, if they're in an ICU room, for example, and things get worse, to the point where despite the best of healthcare, people or the individual passes away. Now, normally, if somebody was to get so sick and was to pass on, family would visit, there will be prayers, there'll be mourning. There's an opportunity for the family to come to grips with things. There is an opportunity for goodbyes. All that is taken away in COVID because once again, it's a contagious disease. So people can't visit, they can't go out. If somebody has to be intubated very quickly without actually having any opportunity to explain this to the family suddenly gets told, I'm sorry, but mom, even then, you may be lucky because sometimes there's a delay, right? Mom has that she's now on a machine, you can't talk to her, we'll let you know how things go. 2 days later, sorry, but mom's dead. Not in those kind of exact words, but my point is, it happens very suddenly.
Yep.
It happens without any process or any opportunity to mourn and grieve. And dying isn't just about the individual, it's also about the family unit, about coming to grips with things, about being able to accept such changes. Now, once again, imagine the mental consequences on not just the people who are in ICU, but the family, how they have grips with all these things, and how difficult it is when you can't say goodbye to a loved one.
Yeah, that's a very sobering picture, but it's important that we all know the consequences of getting COVID. So when you talk about long COVID, you mentioned that not everyone gets it, but do we now roughly know what is the percentage? And I'm sure vaccinations prevents this, right?
I can't give you a percentage because I'm not aware of it, to be honest with you. We can look up studies. The biggest studies were, if I'm not mistaken, in the US and the UK, because once again, they have been having quite a lot of cases over the past few months. And it's the UK especially, having had a pretty nasty winter last year, they've been looking into all the different manifestations. So all the different symptoms I mentioned to you earlier on is based on studies from there. But I don't know the exact percentage, to be honest with you. The role of vaccinations, once again, is not just to take a step back. We have to get rid of the idea that vaccines are there to stop diseases, full stop. It's there to reduce the complications. It does definitely reduce the risk of you contracting it. It definitely reduces the risk of you passing it on to others. But the most important aspect of all the vaccines, irrespective of the brand and whatnot, is the fact that it reduces the risk of complications. By that, I mean ending up needing ICU level care or dying. And I've seen this in practice as well. I've had patients who've been vaccinated who have contracted the virus, but do relatively well given their age or given their other medical issues. So these are things that we see not only in studies, but in real life as well.
And you mentioned also that long COVID, of course, it kind of drains someone of their resources and reserves, and that's why, people who smoke, let's say for example, their lung reserves are not there to compensate. So I guess, and I know this passion subject for yourself in your profession, in your subspecialty, I guess now is a good time to stop smoking. Am I right?
Oh yeah, definitely. It's always a good time to stop smoking. Yesterday, today, tomorrow.
Yeah.
Smokers, I think there are two things. One, it's more difficult for smokers to get rid of infections because of the way the airways are affected.
Cool.
So once you catch it, it's more difficult to get rid of things. Now, once you, as you mentioned, if you are a smoker and you've been smoking for a long time, then you may have over time reduced the capacity, reduce your ability to deal with any insults to your lungs. So that's one of the other problems as well. But surprisingly, the people who tend to do worse off in terms of outcomes are not just people with lung disease, but people who have got diabetes, people who have got ongoing or chronic kidney disease, heart disease, and those who are obese. So these are the kind of key comorbidities or key diseases that tend to push someone towards having a more complicated form of the disease.
Okay. Someone here has commented in the UK, it is estimated 1.7% are suffering from long COVID. I'm presuming that's 1.7% of COVID positive patients. Thank you, Karen George. I just want to ask also, a lot of people now, when they think about COVID, they think, what is the cure for COVID? What can I do to what drugs do I take if I get COVID? To cure COVID, right? And one of the names of drugs that has been floating around is Ivermectin. Okay, now I have. So what is the updates about Ivermectin? I know you just had a forum 2 days ago, whatever. So definitively, what can we say about Ivermectin and its place in its use to cure COVID?
I think so. I wouldn't use the word definitively.
Okay.
Because maybe once again, if you take a step back, the way, and I know you agree with me on this, but the way we approach medicine is we need to be evidence-based, and we need to be humble enough to know that there are limits to what we know, and that things change all the time. So we go by studies, we go by appropriate research to know that what we're doing is not only appropriate for the patient, but is safe to do so. And when it comes to ivermectin, what I can say is at this point in time, there isn't any conclusive studies to show that it either prevents or cures COVID-19. Now, there are many studies that are ongoing, and I know there are very, shall we say, passionate individuals out there who would defend its use or who would advocate its use. But once again, it depends very much on what we can find, what we can see in terms of the research that's out there. And as far as I know, there isn't any drug, not just for COVID, but for most other diseases that not only prevents, but also cures and then gets rid of a disease after 2 days. The problem here is that there's so many different claims as to what it can do, right? I've met someone who's convinced that if I were to give all my ICU patients ivermectin, they'd all be out of ICU within 2 days. I've had patients who come in already on ivermectin who unfortunately not do well, even though they have gotten their ivermectin illegally. There are patients who would say, or individuals who would say that you need to give a certain dose. But the point is, we don't know what's the right answer because the studies have not been done. So I would love for there to be a study that one day shows, look, if we give X amount of dose over X period of time, these are the outcomes and it would be better for the patient. Then great, we should advocate it, we should adopt it. So we shouldn't be dogmatic in the approach. There's always this kind of ongoing thing where they say, oh, he's pro-ivermectin, he's anti-ivermectin, he's pro this, he's pro that, or anti that. And I think that's wrong. It shouldn't be binary, right? It's a spectrum. We need to know its place. And that's how responsible medicine is practiced. You don't just take what's being viral on WhatsApp. You don't just take what's popular at that point in time, even if we are living in very desperate situations, because we don't always have a clear idea of the consequences of actions if we don't have the proper studies to back them up. So that's a very long way of giving you a definitive answer.
Well, for me, it's definitive enough in the sense that we don't know now, so don't rush into it. I was reading an article where they say that the lab studies showed that yes, the ivermectin can fight off the virus. This is a lab study, and the dosage, however, of ivermectin needed to fight off the virus in the lab is 4 times the max dose in that the adult body can sustain. So right, so I think in a way trying to say, look, you have to invent a new ivermectin, supermectin to combat COVID-19 in real world situations.
I think if they're going to patent a new drug, then I think supermectin is a very good idea. You should patent it quickly before someone else, right?
Yeah.
A friend of mine actually did some calculations. According to him, it's not 4 times, it's 30 times what's the current approved rate by the FDA.
Yes.
But once again, there's a lot of excitement sometimes when people say, look, this worked in the lab.
Exactly.
But it's very different to take a virus or a living cell and do stuff to it. You can pour Clorox on it. You can, another famous one is kunyit, turmeric. So there are lab-based studies where if you put kunyit onto the cancer cells die. Fine, but once again, the concentration that's equivalent to a human consumption, maybe many times what is humanly possible. And at the same time, as you can imagine, the environment of a petri dish is very different from the environments in a body. So things don't always kind of correlate.
Exactly.
So science or lab-based basic science studies are very, very, very important to perhaps start off as a proof of concept. But it doesn't automatically mean we can extrapolate it to the end outcome that we want. And that's once again why doing the proper studies in the right way is very important, so that we don't get misled by what we want to believe. Trust me, most of us, we want to believe these things, right? If you tell me that if I eat kunyit, I don't get lung cancer, every day I am going, right?
Yeah, this is just my observation. I think nowadays a lot of people are jumping on board. Oh, ivermectin this, hydroxychloroquine this. It's because science is very messy. Developing new cures, new vaccines is very messy, right? And the messy process last time, perhaps the lay population are not privy to it because it's not a pandemic. But now, because it's a pandemic and we have social media, the lay public can monitor the messiness of science in progress. So every new piece of information, it's a clickbait, it's a headline. It's like, oh, ivermectin can use. Then they go, why the government never use? Because they are privy to the messiness of the science process, and we can monitor in real time, as opposed to last time we don't know. So I think that's why nowadays it's important for people like you with voices of reason to calm the ship and say, okay, I understand, but let's wait for the studies to come about, because there's no point every time if we just people want to diagnose and treat by headlines, media headlines. Do you find that now?
I think you raise a very, very important point. You're absolutely right, because science is messy, and knowing the methodology, knowing what is right takes time. I mean, we have various modules, and we take lots of time in medical school and postgraduate training to understand, right, what is evidence-based medicine, how to design a trial, what makes a trial appropriate, looking into different types of biases that can prejudice one's results. These are all things that are very complicated. And if you ask, until today, if I have to do stats, right, statistics on studies or to understand it, I'll need to pick up a book, because the formulas, not just the formulas, but the right formula, all that, it's complicated, right? To actually assess things properly, it takes time. And you're absolutely right. It's a messy process. And I remember when I was graduating, one of my professors at the time told me that, whatever you've learned in medical school, about 50% of it will be obsolete by the time you're a consultant. And the whole point of that kind of statement was not that I've been learning stuff that's wrong, but that as time goes by, as science evolves, as things change, as new diseases come up, as new medications come up, it is my duty as a doctor to be updating myself, to know what's right, what's wrong, to not buy into the fad of the day, and instead to be able to have a very objective, rational view of what's good for my patient and what's not. Mm-hmm. And this will continue for the rest of my life. If I was the exact same doctor who believed the exact same thing in 20 years as I do now, you have my permission to slap me, because it just means I progress as an individual, right? And I think you're right. This whole process is very much out in the open. So every little thing is nitpicked on, right? I'm very sure that 1 year ago, my thoughts on COVID was different from what it is now. Mm-hmm. And if you want to pick a video of me talking about COVID 1 year ago, I might have said something very contradictory, because the evidence may not have existed at that point. If you think about, maybe not exactly 1 year, but let's go to January 2020. I remember thinking in January 2020 that it's probably just the flu. It's probably similar to influenza. After some time, it'll just go away. Things will get better, and it will go on to normal. And how wrong was I? But you could pick that up, and you could say, "Tengok, Dr. Pakar pun cakap macam influenza aja."
Yeah.
Right. And then you see already how it can be misused, it can be misconstrued. But once again, these things evolve. Just as the virus evolves, we have to evolve as well in terms of our thinking and the way we approach these things.
Yeah, I mean, and don't give ideas to the the anti-vaxxers. No, they get a clip. They get a clip from Dr. Helmy, January 2020.
In theory, doesn't exist. Yeah, sure.
Yeah, exactly, right. Okay, this is a pretty interesting clinical question from my wife, who she wanted me to ask you this. A lot of people may not be aware that severe COVID patients when they ICU, they are actually put on, I believe, on their stomachs. They're lay prone. So, do you know of any evidence that awake proning has benefits, and why is it important?
So I suppose a simple way of putting it is that so when you're lying down, right, the blood vessels and the blood flow is shunted in a certain way. So there is a predisposition to certain parts of the lungs. Just as when you're lying down, there would be some pressure on certain parts of your lungs, and only certain parts of your lungs can expand better. If you lie down on your back, for example, you can imagine that this part is kind of being able to move a bit more. And if you were to lie on your front, on your stomach, then the pressure is here. The shift in gravity also actually shifts the blood flow. And then the lungs that are more posterior, the lungs that are, when I say the lungs, the parts of the lungs that are at the back are also allowed to expand a bit more. So the theory, there is this kind of shunting in terms of the flow, in terms of your ability to actually breathe, and you're making more parts of your lungs work harder. Now, it doesn't always work. There is some evidence to say that it works in the context of COVID, because once again, you're recruiting lungs that are collapsed. So the other thing to bear in mind is your lungs are like many little balloons, right? And when you take a breath in, it inflates. When you breathe out, it decompresses. So if you were, say, lying down all the time, then you may find that the posterior, the back part of your lung, is not inflating as well as it can potentially do. So allowing it to expand, allowing it the opportunity to get oxygen in, would allow you to recruit more parts of your lungs. So that's where things like physiotherapy, in terms of your respiratory function, when moving around, sometimes you don't even have to lie in front or on your front or on the back. You could just even lie on your side, and it makes a difference. Because if, let's say, you have a very bad lung on the left side, then you may want to improve things there. But then if you have a very bad lung here, and then you lie on your right, then you may be compressing this good lung that's keeping oxygen going, as opposed to doing the other way around. So there's lots of mechanics involved, but it boils down to this flow and the expansion that I'm talking about.
Okay, so it sounds very it's a common sense maneuver when you put it that way. Also, when people with severe COVID, they are put in the ICU or they are being treated for severe COVID, I hear, or even my wife says that steroids are used sometimes. Are steroids effective in any way in alleviating the symptoms of COVID, or in helping treating COVID?
So it's not just about alleviating the symptoms; it saves lives. And once again, we know this once again because there was something called the recovery trial. The recovery trial is a series of trials. And one of the things that they looked into was the role of steroids in mortality rates. So basically, by giving steroids, do people survive or do people die? Does it have any improvement? Because the thing to bear in mind is, it is not the virus itself that usually kills people. It's the reaction of the body towards the virus. And what happens is your lungs become inflamed. Inside, it becomes very swollen. So the thickness of your airways, the inability for oxygen to go in, those are the things that drop or lower your oxygen levels. Those are the things that can make life very complicated. And steroids have a role in reducing the inflammation, in allowing oxygen penetration to improve. So steroids definitely help. There are other drugs that also work via different pathways that can reduce the inflammation, that can help bring about better resolution of your airways. And these are the drugs that we use in order to attempt to get the patient better. So if you mention ICU, so in ICU, it's twofold. You give all these drugs, but sometimes it takes time for improvement. And whilst waiting, you need to support the body as much as you can. So you may start off with simple oxygen, but if simple levels or low levels of oxygen is insufficient, then you need higher levels of support. You may need something called a high flow nasal cannula, where there is a tube that goes into your nose, air is pumped in of a certain pressure, but if that doesn't work, then you may need to be ventilated. So one of the things that we see daily in terms of the numbers is alat bantuan nafas, right? The ventilator. And these are people who essentially have a tube stuck into their trachea, into their airway. It's connected to a machine. They are put into a coma, and the machine takes over the function of their lungs. And this is where you have a situation where, because the patient has reached a point where things are so bad that they can't breathe themselves, they may not be able to take deep enough breaths, they may be too tired, and the machine takes over. That is a very critical stage. And in some cases, the doctors, in discussion with the patient or the family, may decide that a ventilator may not even be suitable, because not everyone who goes on a ventilator will be able to come off it. And these are very difficult, very tricky conversations to have.
Right. Knowing the audience, yes, steroids do help save lives. That does not mean you should take steroids on your own before you get COVID. Okay, just very important disclaimer.
In fact, you know how in India there was this whole issue of like black fungus. Did you ever come across videos of that or pictures of that?
Oh no, black fungus, no.
Oh, okay. So, well, Google it later on. Black fungus, India, COVID. But essentially, steroids are not harmless, right? Every medication known to man has got its benefit, it's got its risk, and it's always about balancing the two. So if you were to take steroids without really having any real indication, there are lots of consequences. One of which is it can dampen your immune system. So those are things to bear in mind.
Okay. Another thing I want to ask also, it's so my wife told me this very scary story. Okay, she was seeing a patient. I think he was 70 years old. I think COVID positive, but he was walking and talking and smiling and just like you and me right now. And then part of her checkup on this patient was let's just put the oximeter, and the oxygen saturation was 70%. And then she was like, holy shit. She didn't say holy shit. I said holy shit when she told me the story. So she immediately put on the high flow mask, monitored him for, I think it took about 10 minutes for the oxygen saturation to go up to like 96%, whatever. So happy hypoxia is something superbly dangerous. What happens in what is happy hypoxia, and what happens in happy hypoxia?
Hypoxia basically means that the level of your body's oxygen is low, the hypoxia. And the term happy hypoxia is basically like you described, someone who's got very low levels of hypoxia, who on the surface seems absolutely fine. Now, the danger is that level of being fine, or rather that stage in which someone is well and there is no consequence, may not last for too long. Because once again, you may end up exhausting reserves. You may have a situation where, without you knowing, your oxygen levels start to go down, and then you may reach a critical point where things just catastrophically collapse. Interestingly, when it comes to oxygen, younger people tend to do better in this. Oh, let me rephrase it. It is more difficult to catch symptoms amongst younger individuals sometimes, because if, let's say, you're an 80-year-old chap with various medical diseases, even a little bit of a drop in oxygen is probably going to lead you to have some sort of symptom, because once again, there are no reserves, there's no backup. So if an oxygen drops from, say, 100% to 80%, you're likely to see some degree of difficulty breathing. Maybe you'll start talking in short sentences. There'll be something that was not quite right? So it's easier to pick up. Whereas if you're someone who is younger, who is fit, say a 30-year-old marathon runner, what may happen is your oxygen levels are, or rather you feel fine, because as things drop in terms of your oxygen, you use up more and more of your reserves, right? You don't really feel anything, up to a point where it's so low and you've used up all your reserves that you just go, okay, you drop. So it's a bit more difficult to catch those individuals sometimes because they just appear so well. The difficulty, of course, is these are once again not things that are binary. It doesn't mean every old person will behave that way. It doesn't mean every young person will behave that way. This is talking very much in general terms. And there is a movement, and there are some people who advocate that if you do have COVID, then the thing to do is to get a pulse oximeter so you can measure things at home. Because if we look at how things are at the moment, the bulk of patients, right, those who are in category 1, category 2, are meant to home quarantine. Now, the catch is, or the difficulty here is, how does one know that I've reached a point where I now need to see a doctor, right? I am fine at home, I think I'm okay, but I just listened to Jason Leong talk about happy hypoxia. What do I do now? And this is something where if you have an oximeter, then yes, that's useful. But then sometimes you can also go by what your body tells you. So sometimes you may find that at rest, you're well, you're breathing well, you're talking well, you're doing things well. But if you were to say stand up and sit down 30 times, just stand up, sit down 30 times in a row, and then sit down, and then just kind of assess yourself. If you're particularly breathless, if you find that you can't even string a sentence together properly, then there's probably some degree of hypoxia. Your body is not responding as well as it should. So these are kind of little things that can be taken into consideration, because not everyone's going to be able to get an oximeter, right? But it doesn't mean that it's something that we should ignore just because we don't have the devices to monitor these things.
Right. Yeah. It's I don't know. Somehow I thought you would reassure me, but it sounds even scarier now. This happy hypoxia phenomenon. But yeah, it's important.
It's important, but also it's not something that I think the nature of these things is you always remember, and we always highlight the dangerous things, even though they may not be so common. And once again, we do forget the fact that most people go through COVID without any issues in terms of symptoms or in terms of long-term effects. But because of the sheer number, the sheer volume
of
so
patients,
even 5%, 5% of 10 is very different from 5% of 10 million.
Yeah.
And this is where it becomes a bit different.
Yeah. We always have a problem synthesizing large numbers, and that's why people think, AstraZeneca will give me blood clots, when in fact it's so low. Yeah. So I know you get this question a lot because Malaysians being Malaysians, Asians being Asians, but you know how when the pandemic first started, there was a lot of, again, vaccine hesitancy or whatever, but there's also a lot of people, I know when this pandemic hits, I'm going to eat this particular food and it will help me prevent COVID, or I'm going to take vitamin D to boost my immune system. I'm going to stare in the sun and then it's going to help me prevent COVID. There's always this other things that people can do or want to do to improve their immune system, whatever. So are these true? And actually, I'm asking you straight up, what are things we can do besides masking or whatever to boost our immune system to ward off COVID?
I think, I mean, you kind of said don't mention mask and all that, but that's okay. If you have an existing disease, optimizing control of that disease is very important. So let's say you've got asthma. Let's say you've got kidney failure. Let's say you've got heart disease. You've got diabetes. The better control these things are, the better the outcome will be if you were to get COVID. So like asthma, for example, if your asthma is well controlled, the risk of complications from COVID with asthma that's well controlled is the same as everyone else. But if your asthma is poorly controlled, then if you were to get COVID, then the exacerbation, the complications will be much higher. So whatever you have, whether it's, once again, diabetes or anything, make sure that's well controlled. That's something we forget. Because I think in Malaysia especially, you've got so many people who are diabetics, right, who with poor sugar control. And that makes an absolute difference in terms of complications and mortality. Now, the other thing is your body weight. Because once again, one of the most important predictors of poor outcome is obesity. And in Malaysia, I think something like 50% of us are overweight or obese. So if you want something simple in terms of how to protect yourself, then whatever that is appropriate in terms of losing weight would be good as well. And that brings into picture, one, decent exercise, but more importantly, eating well. And we talk about eating well, we're talking about, there's a whole different conversation, right? How do you eat well and blah, blah, blah. So these are the more boring but more important things to bear in mind when you want to protect yourself. Because, once again, everybody wants a pill that they can take that's going to protect them. But it's not as straightforward as that. There is absolutely no harm in taking your multivitamins. I would argue that if you have a proper balanced meal, then the need for additional multivitamins or additional supplements are negated. So once again, depends, right? If you are someone who unfortunately you're not able to get your fresh vegetables, then you may want to top up with a multivitamin tablet, for example. There is some evidence that if somebody is low in vitamin D, adding vitamin D when they get COVID can improve outcome. So, but we have to put that in context, right? Somebody who's got COVID, who has been tested and has got a low level of vitamin D, giving them vitamin D helps. That doesn't mean all of us should go out and take vitamin D, because just like anything else, if you were to pop in vitamin D tablets and it goes too high, then you get other problems. So you don't want to you don't want to create a problem when it wasn't one that needed to be created in the first place.
Yep.
So these are little things that would be beneficial and things that we do for patients. But in terms of what's out there in society, I think, unfortunately, I don't have any clever answers, or there's nothing special above and beyond what's on.
All right. We are going to take some questions after this last question I asked Dr. Helmy. So please, people on Facebook, YouTube, feel free to ask questions. And by the way, already so many questions are coming. Thank you so much for spending today's Wednesday night with me. I lose track of the days now. I'm going to ask one last question, Dr. Helmy. The thing is, what do you think currently of Singapore's approach? There's been a lot made about their paradigm shift. Live with the virus. It's going to be endemic. Don't count necessarily the case numbers, but those who are hospitalized and death rates and test, trace, vaccinate. What are your thoughts?
I think as time goes by, we would have to move towards a situation where this is endemic. But we haven't reached that situation yet. We can't just say, okay, it's going to be with us, let's just leave things be. Because it's always contextual. You're looking at not just the numbers, but the impact of those numbers. So if you look at, let's say, the UK, for example, at this point in time, we've got super large numbers, but the death rates, the hospitalization rates are not to a point where it's overwhelming capacity. That may change, we don't know, but that's a key thing, right? It's about what do these numbers mean? The numbers per se are not important. It's how does it impact society? How does it impact our services? Mm-hmm. So we need to bring it down to a manageable level first. We need to stop a situation where people are dying, where people are not getting the optimal care that they need. And then we can talk about it being endemic. Then we can talk about living with it. We can talk about a new norm. So I think as time goes by, globally, we're all thinking that, this is something we'll have to live with. It's about making sure that it's manageable as opposed to being eliminated completely. But we're not at that stage just yet.
Okay. This is a question on Facebook, on Lee Wen. Dr. Helmy, what is your opinion on double masking or wearing of face shields? Are they proven to be more effective than just a single layer of face mask? I think she's asking about going out in day-to-day life. So what's your opinion?
Yes, because if you think about it, this is essentially barriers, right? So at its most basic level, things spread when a virus from person A goes to person B. So any barrier that's in between person A and person B, whether it's distance, whether it's a physical barrier, is going to be helpful. So a shield would definitely help. If, say, someone wants to sneeze, then it can stop things from going onto your face. But also using the appropriate mask. Now, it's also quite important the way you use the mask. Sometimes you see people kind of just putting things on and putting it under their nose, then that doesn't really help because you want to cover this particular area. Yeah. And the type of mask depends very much on where you're at. So like me, for example, as a respiratory doctor, I make sure that I wear a slightly tighter fitting mask that is better at filtering things from coming in. But you may not necessarily need that. And once again, as you pointed out, it could be just a simple double masking of a surgical mask and a cloth mask when you're going out to do your groceries. So these are the things that you need to bear in mind. But ultimately, it's very, very basic. We're talking about physical distancing between you and the virus. So anything physical that comes into place, anything physical in terms of distance, anything physical in terms of avoiding crowded areas, these are your bare, basic, but very, very important things that we always have to remind ourselves.
Okay. This is an interesting question from Karen George, who just now contributed that 1.7% statistic in the UK. This is quite interesting. I'm sure you're up to the task, but can Dr. Helmy please advise how to convince my elderly parent that buying roti at the local kedai runcit is not safe? Is there a non-scientific way to do this, because no advice that I can send from Sydney is working?
I think the most important thing is to understand that parents rarely listen to their kids. I think no matter how much information and things that you're going to blast and share with them, so you need to find out what makes your parents tick. And I think you need to figure out who they would listen to and why. I'll give you an example. I have a friend whose parents didn't want to be vaccinated. And no matter what he said, They wouldn't listen to him. And this guy is like, well-respected doctor and all that. And eventually, the mom decided to get vaccinated because her circle of friends, someone sent in this thing about how basically if you were to get vaccinated, then you can go for a holiday, right? Simple as that. Nothing to do with health or living longer, right? That worked. So it goes back to what I suppose makes that individual tick, because when it comes to behavior, right, everyone behaves differently for different reasons. So maybe that going out to buy roti at the kedai runcit is that only source of social being able to socialize with someone. Maybe it's the only time of the day where I'm out of my house and I can get a bit of fresh air, and it's not about the roti itself, it's about the going out. So I think being able to figure out what is the kind of thinking or the motive behind these things is quite important. And then you start to sympathize a bit more, like, okay, it's not just about the roti, because you can just buy stuff online, right? But you can imagine if an elderly person is cooped up indoors all day long, they would long for some sort of companionship, and it may be just as simple as going out for a walk.
Wow. Sorry, I have a big smile because that was a very holistic answer. Thank you. Heartwarming. Heartwarming on a cold Wednesday night. So yeah, Karen, Josh, I hope that answers your question. I think there's a good point. No, I know my parents, I know my in-laws. They may just want someone to talk to. So that's very good, very well done. So there's another question here from Kok Si-san on Facebook. What are your thoughts on mixing vaccines? I'm going to get my second dose of Sinovac, but if given a choice, I'll rather take Pfizer or AZ. I have serious concerns about the efficacy of Sinovac, especially against the Delta variant. Is it a good idea to get a booster dose of the mRNA vaccine if it comes later on? So there's like 25 questions in one question. But generally, it starts off with, what are your thoughts on mixing vaccines?
So this is another developing scene, right? So once again, if you were to ask us, say, even 3-4 months ago, we'd be like, no, don't mix vaccines. There are no studies to show it works. Why would you want to mix it in the first place? And then in real life, we find that, turns out person gets maybe an AZ vaccine, has a bad reaction. What do? Do you just leave it be? Do you try vaccine number 2? Do you try a different vaccine? So as time goes by, you'll get more and more studies looking into these issues. Now, it's very difficult to give you a clear answer as to which mixture is best, or even why you should do it. But let's say the AZ and Pfizer, for example, there are studies coming from the UK, from Germany, and from Canada, I believe, that shows that if you were to take a first AZ dose and a second Pfizer dose, for example, then things get better, in the sense that you do have adequate protection, that it works just as well, if not better sometimes, than the original concoction. Now, whether or not it mixes with everything, it depends very much on what studies have been done and when they'll be available. Because we can't just say that mixing, say, dose 1 Sinovac and then, let's say, Sputnik as dose number 2 is going to lead to a particularly good outcome. We don't know that yet. As for boosters, it's the same thing. Countries like UAE, right? They are looking into having third jabs for the more vulnerable. Even in Israel, they're looking at third booster jabs for those who are more vulnerable, in the thinking that this will increase levels of immunity, levels of antibodies. But at this point in time, the jury is still out. There isn't a definitive answer as to whether one needs a booster dose or not. If we go by the thinking that this is going to be endemic, that we're going to have a situation where we have new strains every so often, there may come a point in time in the future where a particular strain is resistant to the current vaccines, and we'll then need to race to develop a vaccine that's able to counter this particular variant. As of now, even like with the Delta variants, the vaccines work. The key thing, though, is to ensure that you get both doses. So you don't just take one dose and things are okay. You need to get both doses. You need to wait for your 2 weeks after your second dose before you're protected adequately. So these are the things to bear in mind, because once again, these are evolving things. The virus is not just static. It's not just going to stay there and allow us to kill it off. It's going to keep evolving, and we need to play that game and play that race where hopefully we will win, but ultimately it's always going to be a bit of a catch-up.
All right. A very good primer on mixing vaccines. Thank you very much. Again, so this on your position as a physician in a private hospital, by Devan Tiaraja. Is there any move to share the load with private hospitals? I think that's the way forward. We can't have lockdowns further. We can expedite vaccinations involving GPs and clinical kesihatan with the involvement of private hospitals. And I think I'll tie it with another question which was asked earlier on, before we even began. How can private hospitals help?
So we're already helping. So if I were to use the example of my hospital, or rather, it's not mine. If I owned it, it'll be a different story. But the hospital where I work at, we've had a vaccine center there for many months now. And by a vaccine center, I mean we are a place where the government gives us the vaccines to give it to people. And initially, it was healthcare workers, not just for our staff, but hospitals and clinics from the neighborhood or from places that were geographically quite close to us. More recently, there's been a vaccine program for the public. So not just people. So there seems to be a misconception that some private hospitals can give vaccines out to patients, but essentially we are working as a vaccine center where we get told who will be given the vaccine through My Sejahtera. These individuals come in and then we give out the vaccines. So that's one way of doing it. The other way that we've been helping is, of course, actually looking after COVID-19 patients ourselves. So we have dedicated wards, we have ICU beds, all specifically for COVID-19. But once again, as you can imagine, it being a contagious disease, it's very difficult to just open things up just like that, because you need specific infrastructure, you need specific mitigation in place in order to prevent things from spreading, and you need adequate staffing as well. There's no point saying I can give you 20 ventilators if you've got only staffing for 2 ICU beds, for example, right? Mm-hmm. The ventilator does not equate to the care behind an ICU bed. And last but not least, another way that some private hospitals have been helping out is by taking over non-COVID cases from the public side. So, for example, one of the things that my hospital, or the hospital where I work at, has been doing is they have been accepting cases from a government hospital that involve emergency angiograms. So patients come in, they get admitted in the first ED, they get transferred across to the hospital where I work at, and then they get their angios there, all under the same kind of, I suppose, the patient basically doesn't pay anything. Similarly, we are in negotiations with a neighboring hospital where hopefully, maybe as early as this week, if not next week, they'll be transferring cases that are non-COVID related so that we can help look after them. So these are things like elective surgeries, cancers, things that basically you can treat and place in a normal ward that doesn't require all the special stuff that is required when it comes to COVID.
Okay. So on that note, I think it's a good place to end here. We have spoken for 1 hour. We went by so fast. Yeah, what's your final message to all those who are listening and watching? We have about close to 400 people at our peak watching. So what are your final messages to everyone?
I suppose is that things I'm very sure things will get better. I think it's just a matter of time. I think at this point in time, many are angry, many are frustrated. But I do think that one thing we've learned from this pandemic is that irrespective of what the policies may be or what's happening upstairs, shall we call it, many Malaysians have come together. I think many Malaysians have shown a lot of kindness when it comes to helping people who need help. And I would urge us all to dig deeper into how we can help, to look into how we can help others. I think one thing we must not forget is our humanity. I think we should do what we can to help those who are definitely in need, putting aside the frustration. And I started off when you asked me about how bad things are. And I just always think about how, as bad as things are, there are always people who are worse off than me. So I think it's as difficult as it may be, I do feel that we should always think about our society and how we can help them better. It's a very long-winded way of saying don't despair and let's help each other get through this, because I do think that it will be over. It's just a question of when.
Yeah, I think helping each other is the best message we can apply to our lives now. So thank you very much, Dr. Helmy, for spending your Wednesday night with me. Thank you very much. And thank you to everyone watching. Stay safe, and I'll see you next week. Bye-bye.
Bye-bye.